Good evening and welcome to tonight's Men's Health webinar with Dr. Abram McBride. Tonight, we'll be discussing erectile dysfunction, the signs, symptoms, and treatment options for it, and its connection to heart disease. During tonight's presentation, you're invited to ask questions using the chat function, which will be on the bottom of your screen if you're on a laptop, and on the sidebar if you are using a mobile device. Simply type in your question, submit it, and Dr. McBride will answer it at the conclusion of his presentation. So without further delay, I'd like to introduce Dr. Abram McBride.
Good evening, everyone. Thank you for attending. And as Mike said, tonight we're going to be talking about men's health in general, but specifically erectile dysfunction, how it relates to heart disease, and some available treatment options. Before we get started, this is just a little bit of an overview of who I am. I am a doctor, not a computer or something like that, but I'm a urologist. I trained various places across the country, and I'm a fellowship trained men's health specialist. So essentially my entire practice is taking care of men and unique problems that can happen to men throughout the course of our lifetime. So next we going to kind of dive right in here and talk about erectile dysfunction and kind of what it is and you know, who gets it and those sorts of things. So just very superficially, erectile dysfunction is defined as the inability to achieve or maintain an erection that is firm enough for sexual intercourse. And it's actually much more prevalent than most men realize. In fact, about half of men over age 40 have some degree of erectile dysfunction. And I flipped past that last number there, but that's about 40 million men in America. So quite a large number of men have some degree of erectile dysfunction. Probably someone you know or several men that you know have this type of issue. Now, here we see in this picture all the different causes of erectile dysfunction kind of split up into broad categories. And I'd like to bring your attention to the two largest categories, which are diabetes, which comprises about a third, and vascular, which is kind of cardiovascular disease, blood vessel disease, things like that. And between diabetes and vascular, that accounts for well over the majority of cases. But what's unique is men with diabetes over time tend to develop vascular issues with getting a natural erection. And so many of these men with diabetes will turn into a vascular type of issue with erectile function over time. So that's why tonight, being that February is Heart Health Awareness Month, I want to raise attention to the relationship between erectile dysfunction and cardiovascular disease. So before we dive into that further, just a brief overview of what an erection is or what it's supposed to be. So obviously, and you see here on this column, I'm not sure if you can see my pointer here, but in this more left-sided column is when the male is not aroused or relaxed, if you will. And this right column is when the patient is aroused. And so what's supposed to happen is when you are aroused, you're with your partner, you have that emotional and physical connection. There's communication between your brain and the penis, and essentially the small arteries that are normally relatively closed, they then open and allows blood flow to flow into the penis, which then leads to engorgement and stretching and expansion until you have a full erection. So that's the first phase. The second phase is inside the penis, these dilated areas with blood flow are designed to trap that blood flow so that the erection can be sustained and last until the completion of intercourse. So that's what is supposed to normally happen. And throughout the talk this evening, we're going to talk about some issues in that process that lead to erectile dysfunction. But lastly here, before we move to the next topic, erectile dysfunction, as you can imagine, and some of you may have already experienced, it can have a broad and unfortunately many times negative impact on a patient's overall quality of life. And obviously this is something that the male patient experiences, but it's something that their partner experiences as well. So it can lead to distress and friction and frustration in the relationship. I've seen a lot of patients who have depression and a lot of self-image issues. And so erectile dysfunction is more than just, you know, do you have an erection or not? It can really affect a lot of different aspects of a person's overall well-being. Okay, so we've kind of alluded to this throughout the topic so far, but let's dive into this connection between erectile dysfunction and heart disease. Well, we first became aware of this in the medical community by several data studies and data that have been researched and published that indicate that erectile dysfunction symptoms, so difficulty having an erection, difficulty maintaining erection, these symptoms may actually be an early warning sign or indicator of underlying heart disease. And we know that the symptoms of erectile dysfunction may be present as early as 3 to 5 years before symptoms of cardiovascular disease may be realized. And when you follow these patients with erectile dysfunction and they go on to have heart disease, and you look back, erectile dysfunction in some cases is the only warning sign of heart disease. But many of these men will have other issues such as high blood pressure or high cholesterol or diabetes or things like that. So this is a little bit of that timeline, kind of showing you in a different format when a male patient may first experience symptoms of erectile dysfunction, and then over time, this progression takes place. And then ultimately, and unfortunately, some men will actually have an event, maybe a heart attack or stroke. And then all of a sudden, attention is really brought on to the situation, and all of this gets diagnosed and treated and those sorts of things. So for me, I kind of view my role in this. Men come and are seeking treatment and evaluation for erectile dysfunction. I'm trying to find those guys, hopefully early in this process, and get them the appropriate care that they need so that they never get to the point of having a cardiac event or a heart attack or a stroke or something like that. So now this is the really complicated medical textbook picture that explains the association between high blood pressure or tobacco use or diabetes, and ultimately leads to what's called endothelial cell injury. And I know this is a very complicated picture and I don't expect you to take much from it, but really it comes down to these endothelial cells. And these cells are vitally important to the health of the blood vessels that are responsible for bringing blood into the penis, as well as trapping that blood flow to maintain the erection so that the erection lasts long enough. So this is the picture that I think really makes a lot of sense. So obviously on the one side of the screen there, you see a blood vessel. And when you look at a blood vessel anatomically, there's really 3 different layers. So sort of this outer layer, there's the middle muscular layer, and then the innermost part here, right next to where the blood flows through the vessel, this is called the endothelium, or it's where the endothelial cells are located. And so all the blood vessels in our body have these endothelial cells, and they're very special cells in that they can what's called auto-regulate or control the flow of blood through very small vessels in the body. And so for men, the very distal branches of the pudendal artery that carry blood flow into the corpora cavernosa through the cavernosal artery, the blood flow through the cavernosal arteries is regulated by the endothelium. And so therefore, healthy endothelium is very important for having healthy blood flow and healthy erections. So why would an issue with erectile dysfunction perhaps be an early warning sign for disease in blood vessels of the heart or disease in the blood vessels that go to the brain? And as you can see here on the far left, the diameter of the arteries that carry blood flow into the penis are actually quite small. Most of the times when I'm doing a penile duplex ultrasound study and measuring these vessels, they're about 1, maybe 1.2 millimeters in diameter. You compare that to the next step up here, the blood vessels that carry blood flow to your heart, they're about 4 to 5 millimeters. The carotid artery that goes to your brains, 5 to 7 millimeters. So you can imagine any process that's leading to plaque buildup in one of these bigger arteries can have a much more significant blockage in a smaller artery that carries blood flow to the penis. So as that plaque build up and that process takes place over time, decrease in blood flow to the penis may happen several years in advance to decrease in blood flow to the heart or the brain. So like I said before, this is a time to, I always talk to the patient and see if they already have any of these medical conditions that are linked to heart disease, make sure they're getting appropriate treatment. But I do find men, unfortunately, fairly commonly, who really haven't seen a doctor before, and they don't know what their blood pressure is or their cholesterol levels, or maybe they smoke or don't exercise. All these different things that can be changed or treated to try and reduce someone's risk for having heart disease. Okay, so that's the connection between erectile function and heart disease. And as you can see, that's very important and really, in many cases, an alarm bell or an indicator that we need to improve a patient's heart health and their vascular health. But in terms of the erectile dysfunction, obviously, it's still an issue. And for many of these men and their partners, they really seek treatment and want that to hopefully be improved. So, what are the different treatment options that we have available for erectile function? There are several, and many patients will first talk to their primary care provider, or perhaps they'll come in and see a urologist. But ultimately, the buck stops with someone like me, if you will, who is a fellowship trained men's health specialist. And so this is sort of, like I said, what I do in the majority of my practice. But really, realistically, here's the menu. These are all of the FDA approved therapies, and I emphasize FDA approved. You'll note that I do not have low intensity shockwave ultrasound therapy on this list. I am going to spend about 10 seconds here and address that. It is not an FDA approved therapy. It's experimental. We offer that in our office. For the right patient in the right context, it's a good treatment option. Unfortunately, I think a lot of men are persuaded into pursuing treatment with that, and they're not necessarily good candidates for that type of treatment. And we can talk about that later if there are questions. But if you're wondering, well, where's Shockwave? Why isn't Shockwave on that list? That's why it's not on this list, because technically speaking, it's not an FDA approved therapy. So we're going to go through each of these briefly and kind of talk about them. So first we have oral medications, or the pills. I'm sure everyone on this webinar this evening has heard of the pills, at least one of them, Viagra or Cialis. I mean, these have been around for almost 25 years now, which is pretty incredible to think about. But this is where most patients start. You can get these shipped to your house now. You can pretty much find them anywhere. And essentially all these medications do is, when you are sexually aroused, they then enhance that arousal process and sort of tell your endothelial cells to release more nitric oxide so that the blood vessels can dilate more than they ordinarily would, which will allow more blood flow into the penis to help have a firmer, more rigid erection that hopefully lasts longer. I think a common misconception with these pills is that you take a pill and all of a sudden you're just going to get an erection out of the blue, and that is definitely not the case. Okay, so you still have to have intimacy and arousal and all of those things for these medications to work. They just take your natural erection and make it a little bit better. By and large, these medications are fairly well tolerated, but certainly sildenafil, which is the generic for Viagra, is associated with a long list of side effects, which I thought I had a slide on that. But basically, headache, facial flushing, maybe a little bit of blurry vision. The other one that we commonly use, called Cialis, similar side effects, but more so you can get some heartburn or acid reflux, even some back pain, which is kind of an odd symptom to have. But the pills can be effective. They can be effective in even up to 80% of patients who try them, but they have a high likelihood of having side effects associated with them. But today, in 2022, they are generic, which means they're a lot cheaper than they used to be, and they're pretty easy to take. And so a lot of patients will start here. Now, if the oral medications are not effective, or the side effect profile is very significant and bothersome, then we sort of dive into the remainder of these other options that we're going to go through. And so one of these other options is a vacuum erection device. So essentially, this is a hollow plastic tube, and the patient inserts their penis into the tube. And in this particular picture, this appears to be a battery operated device, which means you just turn on a switch, the little battery operated motor works, and you get a vacuum. And that vacuum pressure will pull blood flow into the penis to achieve an erection and get engorgement. Now the trick with these devices is oftentimes to have while the penis is in the tube, the erection is pretty good. When you take the vacuum tube off, the erection can quickly go away, unless you use one of these constriction bands. And when you look at the side effects and the reasons people dislike this type of treatment and stop using it, these constriction bands, for some people, now some people do fine with them, but for many, they're really tight, they're uncomfortable, they can cause bruising. I've even had a couple patients develop a condition called Peyronie's disease that feel like is as a result of using these. So you have to be kind of careful. So they can do okay at getting an erection, but they're not exactly a huge favorite device amongst patients as to use as the primary method of achieving an erection and having sexual function. So a lot of guys will try them, but in many cases they'll move on to something else. And as we talked about, there's bruising, discomfort, and things like that. And also they're kind of inconvenient. When you're trying to be intimate with your partner and have that moment, you have to pull out this, big kind of clunky vacuum device. And so it can be a little bit of a mood killer for some couples. Now, some couples may like it, but for many, it's a little bit awkward. Another alternative therapy to the oral medications is a particular medication called alprostadil, or it used to be called Muse many years ago when it was still had a brand, was still branded, but the generic is called alprostadil. But essentially, you can take the alprostadil and it can come as either like a little small pellet or suppository that can be inserted into the urethra. And so as you see in this picture, it goes down the urethra tube where you urinate from, and that pellet is inserted and absorbs into the wall of the urethra, and it can then have its effect into the corporal bodies. Other pharmacies have developed a gel version of this that can be used. It's a little bit more comfortable, but I think it's a little bit less effective. The urethral medication here is not something that a lot of people really use. When you look at the success rate, it's really about 50%, which is lower than either of the other two therapies we've discussed so far. And really, most men, pretty much almost everyone I've ever talked to that's tried this therapy, describes some degree of discomfort and pain in the urethra. And that's not exactly something you want to be experiencing when you're trying to be sexually aroused and intimate. So it's very rare that I find a patient who even wants to try this, much less has a lot of good success with it. Another one of the other alternative therapies to oral medications is intracavernous injection therapy. I would say after taking the oral medications for erectile dysfunction, this is probably the other most common treatment that's utilized as far as the medications are concerned. A lot of the men's health clinics here in Colorado Springs and really across America really promote this type of therapy. A lot of times for a very high cost, but nonetheless, it can be very effective. And I have many patients that utilize this type of therapy as well. And basically, what you're doing is, you can see in the picture here, you're taking a cocktail of 3 medications: alprostadil, papaverine, and phentolamine, and you then inject that directly into the tissue of the penis. So every time you and your partner want to have an erection or be sexually active, you then have to draw up this medication and then inject it into the penis to have an erection. Different than the oral medications, this type of therapy will actually give you an erection really whether you want it or not. As long as your body has sufficient blood flow into the penis to have an erection, this medication, once injected, will work usually within a few minutes, and you'll have an erection. Some men like that. Some of their partners like that. Some men dislike that in the sense that it feels a little bit unnatural. But nonetheless, it is more potent. But let's not forget the fact that you have to inject this every time you want to have an erection. And so for many patients, that's the real hang up. The injection is painful, or for some men, the medications, as they absorb into the penile tissue, causes the penis to have a lot of achiness and discomfort. And really, it's not very spontaneous. Again, when you're with your partner wanting to have that special moment, you have to kind of say, okay, time out. I'm going to go get my medication. I'm going to draw it up. I'm going to do this injection. Then by the time you come back, your partner may be reading a book or watching TV or went to sleep, whatever the case may be. And so it's a little bit difficult to work into your routine, if you will. Now, the other therapy that we've not discussed yet is the inflatable penile implant. And for a lot of people, they've actually never heard of this. And I find that a lot in the office where, most of these other therapies, people have at least heard of them or know a lot about them, but the implant is a little bit different. And so I do want to talk about that here for a few minutes. The other thing that's unique about the implant is it does not require any blood flow from your body. So for patients in whom their blood flow system really does not work very well at all, the oral medications are not effective. Even if the injectable medications, they wanted to try that, and the injectable medications are not effective. The implant is the only therapy that can get the job done, can give you an erection that's dependable, reliable. The erection occurs when you want it to occur, and you and your partner are in control of how long it lasts. It's the only therapy that can provide that result independent of your blood flow system. So what I tell patients is this is the only therapy that really works every time because it doesn't depend upon your blood supply. So how does it work? Essentially there's several components here, but in a nutshell, there are two long hollow spaces inside the penis that are supposed to fill with blood flow when it's time to have an erection. And the implant is a pair of silicone cylinders that go into those natural spaces that are already there. And there's a small pump that is located down inside the scrotum. And when you or your partner want to have an erection and be sexually active, either you or your partner can squeeze and release the pump that then moves fluid into the cylinders and an erection can be achieved. And because this is, this implant does not require your blood flow, but it has its own fluid-based system, the erection remains until you or your partner pushes the deflation button, and that releases the fluid, and then the erection can dissipate and go back to the natural resting state. Now, when we look at all these different treatment options that we've discussed so far this evening, and you go back and you ask patients, okay, well, what did you think of the pills, or what did you think of the injections, or these different things? The penile implant by far has the highest satisfaction rate, and some studies will quote as high as 95%, particularly amongst the partner of a patient who has erectile dysfunction. But patients themselves report even as high as 98% satisfaction with this device. And we'll talk a little bit about some of the side effects or issues with that in a second. But this is just that one study I quoted where patients were asked through a validated questionnaire, what is your satisfaction rate? And you can see with the injections, 40% of patients were satisfied, 51% were satisfied with oral medications, 93% were satisfied in this particular study and happy with the penile implant. So before we go into more detail about the implant, I do want to show you a quick video here. And this is a computer animation of a patient who has an inflatable penile implant. And on the outside, no one's going to notice that you have this device. So I always get that question, but if you go back to the beginning of this video right here, everything is on the inside of your body. Nothing is on the outside of your body. So you can be in a gym, you can be seeing another doctor or having surgery or whatever, and no one's going to look at you and know that you have this implant inside. Now, there are three components here, and as you can see, I'm going to pause it again. So as you can see, the patient is squeezing and releasing this pump, which is moving fluid from this reservoir down into the cylinders. And as that pumping process continues, the penis becomes erect. Once the erection is achieved, the erection does not go away until you push the release button and allows this fluid to deflate back into the reservoir. And then once that deflation process occurs, you return to the natural resting state. So let's talk about the ups and downs or pros and cons of an implant. So what are some of the benefits? And I've mentioned a few of these things already, but it's really the only permanent solution for erectile dysfunction amongst all the other things that we've discussed this evening. It is spontaneous. You can be at home in Colorado, you can be on a trip to Mexico or wherever else, and you're ready to go. You have the implant, and when the moment's right, you have the confidence that it's gonna work the way that it's supposed to. You and your partner are in control of how long it lasts. All the parts and components are inside of your body, and it's not readily noticeable on the outside that you have anything done. Patients are happy with this, as we've already discussed. This is an important one. So a question I get a lot is, well, how does sex feel? Does it feel different? Can I still achieve orgasm? Does it feel different to my partner? All these different things. And it's important to remember that the implant the only thing that it does is it makes the penis firm and erect so that you can participate with intercourse. All the other components to sexual function, to sexual satisfaction and pleasure, meaning your relationship with your partner, your degree of arousal with your partner, the emotional connection, the mental connection, all of that still has to be present for you to function normally in a sexual way. All the implant does is when all these other components are in place, the implant allows you to have an erection that is firm enough and rigid enough so that the rigidity in the erectile part of it is not a concern. These implants have actually been around for quite a long time. Now, thankfully, the implants we have today in 2022 are much different than the ones that were around a few decades ago, but nonetheless, they've been around for quite some time, and these are considered very safe treatment options. Now, it is a procedure to have an implant put in. Now, this type of procedure is something where you come in, have a little bit of anesthesia, have the procedure done, and you go home the same day. So in and out, same day type of procedure. And for my patients, you go home. You go home the same day. You come back to the office the next day with a little bit of a wrap around things to prevent some bruising and swelling, and that gets taken care of. And then usually within 7 to 10 days, you can return to your normal routine daily activities. And within 2 weeks, you're clear to do pretty much whatever type of activity you feel comfortable doing. Now, that being said, obviously there is some bruising and swelling and soreness that can take place in that early recovery period. In terms of long-term function of the implant, these implants, unfortunately, and I'm sure Boston Scientific is working on improving this, but as of now, these implants do eventually mechanically wear out or break down. And typically that expectation is around, on the short end, 10 to 12 years, the long end, 14 to 15 years. So I tell most patients a good decade plus a few years is a very, very reasonable expectation for how long the implant can function for mechanically. Now, just like any other device that can be implanted in the human body, such as a knee replacement or a hip replacement or a pacemaker for your heart, any implanted device always has a small risk of infection. And for the penile implant, thankfully, that risk is very low, usually around 1 to 1.5%. But nonetheless, there is a small risk that if that device gets infected, we would have to do some additional surgery to correct that, as is any issue with the device in terms of how it functions mechanically. That would also require surgery to correct that. Now, this is a question I get frequently, and I'm not an insurance specialist, so don't take anything I say at a 100% on this particular topic, because some insurance plans can vary, but in general, it's actually pretty well covered by insurance. Certainly in the case of Medicare, this is always covered, and many commercial plans outside of Medicare will cover it as well. And the important thing to remember is anytime a patient wants to have this procedure done, we always verify their insurance coverage beforehand so that there's no surprises afterwards as to whether or not it's covered by insurance or not. We sort that out before the procedure. So, in summary, at the end of this, this discussion of erectile dysfunction and heart disease, as we mentioned, it's common. A lot of men have erectile dysfunction, and it can be associated with underlying heart disease. And so it's important to always make sure that you're getting proper healthcare, primary care, to make sure any risk factors for heart disease are being minimized as much as possible. There's a lot of ways we can treat erectile dysfunction, and we talked about many of those treatments. And penile implants really offer the only type of treatment that provides a permanent solution. And so it's important to obviously, talk to your partner, make sure you have good open communication, but seek treatment. There's a lot of things we can do to treat this. This is not a condition where you just have to say, well, I guess that's it. That part of my life is over. That part of my relationship is over. There are definitely things that are out there that can help. And if you want to seek that help, obviously you can come see someone like me, a men's health specialist or a urologist. And if you go to this website, edcure.org, it has a little location tool that'll help you identify people like me that are in your area. But I can tell you in Colorado Springs, I'm going to be the person that comes up because this is sort of my area of practice. So with that said, I'd like to thank everyone for listening. And as you see here, this is the number to the office. So feel free to give the office a call if you'd like to schedule an appointment or have any questions. And also I have a website, themensmd.com, that has a lot of great information that you can reference as well. So with that said, we'll open up for some questions. And I think we already have two actually, or maybe just one. I'm not sure. Mike, do you have any questions?
Yeah, there's a question here. If somebody is on heart medication, are they eligible to take pills or utilize any of the other treatment options for erectile dysfunction?
Yeah, that's a great question. So really, the interesting fact with that is when you go back to 1998 and Pfizer was the drug company that was doing the research for Viagra, it was initially studied as a blood pressure medicine to be taken by men and women. And in the clinical trials, all the men were coming back, kind of saying, hey, what is this stuff? This is pretty amazing. And Pfizer realized, they had something. So that being said, these medications can lower your blood pressure a little bit. They're not really good as a blood pressure. I mean, they lower blood pressure, but they're not quite to the extent of most of the other medications that doctors use to lower blood pressure. But they lower your blood pressure some, and there are some patients in whom the blood pressure lowering effects are more significant than others. So really, the only time you have to be cautious is there's a very, very infrequently used class of medications called nitro-based drugs, which is nitroglycerin, nitroprusside. If you take one of those nitro-based medications, you should not also take Viagra or Cialis, because the combination of those two types of medications can really lower your blood pressure quite a lot. Otherwise, these medicines are actually really good for your heart. They really help vasodilate the blood vessels that carry blood flow to the heart muscle tissue. They improve the blood flow to and from your lungs, so that way that blood can get back to your heart more efficiently. Really interesting, in the COVID pandemic, these medications are being used in ICUs very frequently to help get patients off of ventilators and help them. These are patients with severe COVID infections, but they're using Viagra to help people get off ventilators. So it's actually really good for blood flow. It's just, you got to be careful if you're taking those nitro-based medications. You should not combine them together.
And the question, you covered this a bit, but asking about the primary cause of ED. I know you had a slide that went over this, but maybe going back to what are the main contributors?
Right. So there, I don't know if I'll go back to the actual slide, but there's a number of categories of things that can lead to erectile dysfunction. In a very small number of cases, it can be a side effect of a medication. I see patients who have, particularly young patients, it's not so much the older gentlemen, but men who are kind of under the age of 40, who have really, really low testosterone levels. That can be a cause of erectile dysfunction. But in 70% or more of men who have erectile dysfunction, it's usually related to either diabetes or vascular disease, which, as we talked about with the endothelial cells, when those endothelial cells are not healthy, the blood flow not just to the penis, but really to all parts of your body. But as we're talking about here in this topic, the blood flow to the penis for an erection, that blood flow does not work as well as it should. And so you have difficulties achieving or maintaining an erection.
Now, if somebody gets a penile implant put in, is that something that can be reversed and something that they could do and potentially naturally recover function of their ability to get an erection?
Yeah, good question. So that is actually something that cannot take place. So, and really, when I talk to patients about a penile implant, this isn't something that you walk in, you've never tried anything for erectile function. We don't know what your testosterone levels are. So people that come in and say, "Yeah, I just want a penile implant," I don't really do that, because you put an implant, you can't take it out and have and have a better erection or have a natural erection after that. So really you need to, and that's my job, right, is to go through everything, see if there's medical problems that need to be addressed. We try simple things, make sure your hormone levels are normal, maybe try an oral medication, those sorts of things. But if it's pretty clear, pretty evident that there's a significant blood flow limitation to the penis, and that's the underlying reason for the difficulty with erections, in those men, the penile implant is a great option because the blood flow system doesn't work, but the penile implant does. And for those men, there's really not a reason to take it out and go back to how you were, because how you were isn't working. So, but yes, that is important to know, that if it's, for example, it's rare, but I have a patient on like a psychiatric medication that has a lot of erectile difficulties. We try and work on the medication issue first, for example, before we move on to other treatments for erectile dysfunction.
Now, what is the prep required for the implant and how long does the procedure take?
Good question. So prep at home is pretty minimal to none. Just sort of be normal, take a shower. But beyond that, the day of the procedure, in the procedure, it's actually quite extensive. So I sort of have a whole system. I have a team that's with me every time, and it's the team that's with me for every one of these cases. And so we have a system. And so the total time in the operating room is probably about an hour and a half or so, but about 30 minutes of that is spent obviously getting the patient to sleep and making sure they're comfortable. But we do an extensive skin prep. So there's a 5-minute or so scrub with one type of surgical soap. There's another scrub for a few minutes with a different type of surgical soap. But then there's a third scrub. And so all those different scrubs take time. And normally for most routine surgeries, one of those soap scrubs is considered sufficient. I utilize 3 of those. We infuse a blend of antibiotics to prevent infection. And then of course we do the procedure, which usually takes about an hour to hour, plus or minus 5 minutes, but pretty much right around an hour is how long the actual procedure takes. And then the patient goes to the recovery room, a few hours there. And then once they're awake and alert, they're released to go home.
Now, do you recommend that if someone has had ED for a number of years that they do a cardiac workup?
Yeah, I think that's certainly a reasonable consideration. I mean, if a patient comes in and already has a relationship with a cardiologist, and the cardiologist is, sort of on top of the risk factors for cardiovascular disease, then I think the cardiologist I would defer that to the cardiologist. But certainly, if a man's had erectile dysfunction for a number of years, they're not necessarily sure if they have heart disease or not. Yes, absolutely. I would encourage them to go seek out a screening with their care physician. I know here in the Colorado Springs community, the cardiology group that is based out of Penrose Hospital, they're more than happy to see patients just to kind of have a basic screening, maybe do an exercise stress test, just to make sure that things are working as well as they should.
And we're going back to a question on Shockwave. Said it was not FDA approved. Is it something that's still a viable and effective treatment option? That's the question.
Yeah, so let's talk about Shockwave for a second. And I briefly addressed this a little bit. So Shockwave actually came out of Europe. So in Europe, it's been around for around 7, 8 years now, closer to 8 years, and it's approved by their equivalent of our FDA, and it's in widespread use. And in Europe, the research and the published data are very clear on the types of patients in whom it works well for, and the type of patients in whom it does not work well for. In the United States, there have been a handful of clinical trials that have been completed, and the results in the United States are fairly similar to the results in Europe. At this point, though, the FDA has not considered the United States research to be sufficient for approval. Regardless, when you look at the research from the United States and in Europe, really, shockwave therapy should be considered to be like a pill or an oral medication for erectile dysfunction. So it works the best in the patient who takes Viagra or Cialis. Viagra or Cialis works really well. They get a great erection with Viagra. The erection with Cialis is really good. The problem is they don't want to take the pill. It's hard to time. It's hard to work into their routine, or maybe the side effects are very significant. And so for those patients who go on, who have that type of response to Viagra or Cialis, they go on to have shockwave ultrasound therapy. And 85% or so of those patients will have a good response to the treatment, and they'll be able to have the same quality of erection that they would have previously had with Viagra or Cialis. But after the shockwave ultrasound therapy, they no longer need to take the oral medications. When you start stepping out of that example where the patient, now let's say the patient has maybe a okay so-so response to Viagra or Cialis, or maybe Viagra and Cialis don't work at all, and they have to use a penile injection type of therapy or something like that, then the results with shockwave ultrasound therapy really drop off quickly. And so, I tell people all the time, maybe it'll help a little bit. Maybe you do a course of shockwave ultrasound therapy, and maybe now you're improved enough that you can take the pills again, and they work okay. But it's not, you're not in that category where you're going to get a great result from shockwave therapy. And so, contrary to what a lot of wellness clinics and men's health clinics try to advertise, shockwave therapy is not a one size fits all for everyone.
Thank you. I think this question is related to your initial workup. So how many tests do you run to determine what a patient needs? Maybe that's better asked with, like, what workups do you do an initial ED consult to determine how to proceed with patient treatment?
Absolutely. So first thing I do is go through the medical history and medications and kind of work through the medical conditions that may or may not be diagnosed. And obviously, if a patient really hasn't seen a physician in a long time, I'm happy to play the role of a primary care physician. And so many times I've checked cholesterol levels and done blood work looking for diabetes and things like that. But much more routinely, I'll check the testosterone levels and make sure that the male hormones, total testosterone, free testosterone, estrogen levels, et cetera, that all those hormone levels are where they should be. Because if those hormone levels are not normal, even some of the treatments such as Viagra or Cialis may not be as effective. And so my strategy is to make sure all the simple things are addressed first, which would be male hormone levels, making sure those are normal, trying one or two of the oral medications. But if those strategies are not effective, then we start going into this exploration of some of the other treatments that we discussed this evening.
Now, performing the implant surgery, do you use local or general anesthetic?
Yeah, good question. So it is a general anesthetic, but general anesthesia in today's days and times is a lot different than it was even 10 years ago. And so really general anesthesia for these types of procedures is basically just propofol, which is a very quick on, quick off, does not have much of a hangover effect. They very rarely use any type of gas for these types of procedures. So it's just propofol, a little bit of pain medication, and a mild sedative. And so patients are able to recover much more quickly, and that allows them to be able to go home within a couple hours of having the procedure. But absolutely, I use a lot of local anesthetic. So before I start the procedure, There's a lot of local anesthetic that is injected into the internal compartments of the penis where the implant is going to be located. I inject numbing medicine or anesthetic into the dorsal aspect of the penis there and create like a ring block around the base of the penis. And there's also a couple nerves that come out from the deep part of the pelvis that go into the base of the penis, and I inject local anesthetic around those as well. And it's really sort of interesting. The local anesthetic plus a cocktail of medications I have the patient take by mouth right before they go back to the operating room. That combination, really, when the patients come in the next day to have their dressing removed and those sorts of things, I would say probably around half, half or so are quite surprised and tell me that they don't have pain at all. Now, I would never tell someone to expect no pain. I mean, obviously, you're going to have some potential discomfort, but the point is, guys drive themselves in the next day. They're walking out of the office. There may be some soreness and discomfort, but it's not a severe type of pain that you can have with other things.
This question's very specific to this patient, but I think maybe it goes back to your initial workup question. So if someone's still getting aroused, but they're not able to maintain a hard enough erection for intercourse, and they also have a heavy heartbeat, how much you work them up or determine what's going on there?
I'm not sure the heart rhythm is related to the erection. So when I hear that story of whether it's with treatment or without treatment, basically the patient can get an erection. Initially, it may not be as firm as it used to be, 10 or 15 years ago, but it would be firm enough to kind of get the job done. But after a minute or two, that erection fades pretty quickly. Or they're about to go actually, insert or have that level of activity, and the erection just sort of goes away. That is a indicator to me that there's likely a blood flow issue with the penis, but it's not necessarily a problem with blood flow into the penis, but it may be an issue where the blood flow is not trapped in the penis to maintain the erection. So that's the medical diagnosis for that is called venous leakage. So as blood flows in to have an erection, there's unfortunately too much blood flow leaking out of the penis, and so you just can't keep it inflated enough. So you can, the treatment for that is really trying medication therapies, whether it's pills or even some of the more invasive things that we talked about, to get more blood flow in to overcome what leaks out. But in many of these men, venous leakage. So venous leakage. The treatment for that at the end of the day really is an implant, because with the implant, your blood flow system, whether it's blood flow in or the trapping of that blood flow to maintain the erection, that function is not necessary with the implant because the implant works on its own. Now, some patients really want to get into the nitty gritty and have the official, diagnosis for that. And those patients happy to perform what's called a penile duplex ultrasound. And so that's a test that we do in the office where I'll actually inject some of that medication directly into the penis to stimulate an erection. And then we can use ultrasound to measure the quality of blood flow in, but we can also measure how much blood flow is leaking out. And that's how we can definitively diagnose venous leakage.
Now, last question here. What is the recovery like after a penile implant procedure? How long is the recovery process, and what does the patient have to do on their end to ensure a good outcome?
Yeah, good question. Initially there's really not much you have to do at all. In fact, I tell everyone just kind of leave it alone. But essentially you go home the day of the procedure with the gauze wrap around everything, kind of like we discussed. You come into the office the next day and that all gets removed. And in the first couple of days, using ice packs and things like that to keep cold, to prevent, and minimize inflammation and bruising and swelling. After the first couple of days, you can stop doing that. And like I said, usually by around a week or so, patients are by that point back doing their normal routine daily activities, running errands or things around the house, that sort of thing. 2 weeks for going to the gym, running, biking, things like that. And then everybody comes back and sees either my PA or I at 3 weeks. And at 3 weeks, we will teach you how to start using the device, teach you how to inflate, teach you how to deflate, and make sure you're understanding that and learning that process. And if that goes smoothly and you otherwise feel comfortable, I'm okay with you having sexual activity at 4 weeks. Nonetheless, I still like my patients to come back at 6 weeks just to make sure everything's going well. Some patients still have a little question about this or that, but you have that second appointment at 6 weeks to make sure you're well on your way to doing well. So that's the initial phase. I also do what's called, or what I call rehab. So, if you get your knee replaced, you go to physical therapy and you do rehab to work out your new knee. And I ask my patients to do the same thing with an implant. So for the first 6 months after the implant, after you have your implant and you've learned how to inflate and deflate and you're independent in using that implant, for 6 months, I want you to inflate it every day. And you inflate it to sort of its maximum ability to inflate. And you do that process for about 15 to 20 minutes every day, and then you can deflate. And what that does, over the course of 6 months, these implants really fill out the penis a little bit better. So you can get better rigidity. The pump gets a lot easier to use. And quite frankly, at the end of the day, by the time a lot of patients see me, and a lot of patients have been dealing with erectile dysfunction for years, and they've tried all these different things. What unfortunately happens in the background is the penis starts to shrink. And that's an unfortunate reality of erectile dysfunction is the longer the process lingers for, the more shrinkage and atrophy can take place. And so what I've found is having patients aggressively rehab over that 6 month period of time. Trust me, you're not going to gain all of that size back, but you can get a little bit, particularly in sort of the girth of the penis and the rigidity of the implant. You can improve that over that 6 month period of time, and I think that's really important. So that patient, long term, for the 12, 15 years, or however long that implant is mechanically functioning well for, to make sure they're getting the peak potential out of that implant.
Thank you, Dr. McBride. I want to thank you again for taking the time tonight to present all this great information. And I want to thank everyone for attending. Again, Dr. McBride's contact information is on the screen in front of you. You'll receive an email tomorrow with the same information on it. Appreciate you all coming out this evening. And this concludes our Men's Health webinar. Any final words, Dr. McBride?
No, thank you, Mike, for organizing this, and thank you all for attending. And hopefully everyone got some good, helpful information. And obviously, feel free to reach out to the office, and I'm happy to see you for further discussion and review of however we can help you with treating your erectile dysfunction.
Thank you, everyone, again. Have a wonderful evening.
Thank you all. Good evening.